It's a pleasure for me to introduce the next speaker, who does not need any introduction, Professor Carlos Libhaber, but because they give me a chance, then I will try to introduce him. Professor Carlos Libhaber is a symbol of what this morning we heard from Professor Ntombi Foster Ne Mariza, says that we need rebranding. This is the proof of rebranding. In his previous life, he was a cardiologist. I mean, when I say previous life, I don't mean that somebody made a magic, we had the resuscitation, no. He transitioned from cardiology to come as a registrar in a nuclear medicine and become a nuclear medicine physician. And this is a big deal for us because it's been really somebody that's actually talking to all the cardiologists in the country on behalf of nuclear medicine. Professor Libhaber, the show is yours.
Thank you very much, Willie. Professor Dorbala comes to us from America, and of course, I remember that myself, I also come from America. When I say America, people immediately think America, land of Donald Trump, land of Stevie Wonder, Johnny Cash, Bob Hope. You see, all of that is North America. I come from Argentina, which is South America. No Trump. Well, if I must be honest with you, no wonder, no cash, and no hope either. So thank you for having me here. Until the 70s, coronary disease treatment was conservative. What they used to do was to identify the risk factors, use diagnostic strategies, and basically use secondary prevention therapies with drugs to prevent or improve angina, to try to improve outcomes, to try to reduce ischemia. In 1967, René Favaloro took some saphenous vein and he made a bridge from the aorta to after the obstruction in the coronary artery, and that was the first ever bypass graft. About 12 actually years later, Andreas Grunzing in Switzerland did the first PCI. Before that, the hemodynamics department, the cath lab, what they used to do was just to inject, see where there is an obstruction, and call the surgeon. They couldn't do before that any intervention. When this happened, suddenly we have CABG, suddenly we have PCI, so it made sense. If you have flow-limiting atherosclerotic obstruction that was causing angina, was causing ischemia, and also was causing infarction, to be able to open up or bypass the obstruction would solve our problems. So actually, it was clear that it was preventing mortality in acute MI, in acute coronary syndromes because of plaque disruptions, but it wasn't so clear if in stable ischemic heart disease, in chronic angina, it was making such a difference with the outcomes. So now, for stable ischemic heart disease, there were two options. One is the medical tendency, treating inflammation, the risk factors, lifestyle interventions, secondary prevention, or there was the other option, revascularization. So some trials, even then, in the 70s and 80s, confirmed that in stable ischemic heart disease, they could reduce mortality and myocardial infarction in some groups, patients with left main coronary disease or patients with three-vessel coronary disease with left ventricular systolic dysfunction. The trials also confirmed that CABG surgery could improve angina, could get the patient to walk more, better performance on the treadmill, but they didn't prove that they could reduce death or infarction. Eventually came trials like the COURAGE trial, the BARI 2D trial, the FAME2 trials. These trials showed no significant reduction in cardiovascular events. What are cardiovascular events? Death, MI or stroke, when CABG was added to optimal medical therapy. The COURAGE trial was a trial that compared optimal medical therapy and PCI with medical therapy for patients with stable coronary disease. I'm not talking about other coronary disease. So they had like 2,300 patients. Half went to the PCI group plus optimal medical therapy, and the other half went to optimal medical therapy without PCI. And they followed them up for a median of 4.5 years. They followed some of them up to 7 years. And you can see the, no, wrong. Went back. Here you are. You can see the Kaplan-Meier curves for survival from death from any cause and myocardial infarction together. You see the two lines go almost together. This one is for overall survival. This one for acute coronary syndrome. This one for infarction. You see, the lines go more or less together. To make a long story short, they concluded that as initial management strategy, PCI did not reduce the risk of death, myocardial infarction, or other major cardiovascular events when added to optimal medical therapy. Problem with these trials. The BARI 2 trial was done on patients with diabetes. To make a long story short, these studies were unblinded. Unblinded is not ideal. Why not? They didn't have pre-specified threshold of baseline ischemia, so they didn't know how much ischemia each patient had. And they were randomized only after the coronary angiography was known. So what? It means that if they were not blinded, and they only randomized the patient after the coronary anatomy is known. You know, you ask the cardiologist, look, this patient has severe coronary disease. What is the cardiologist going to say? No, you send him for cath immediately and open up the arteries. So those patients were probably excluded. What about no specified baseline ischemia? So if you had patients with moderate or severe ischemia, once you tell the doctor he has moderate or severe ischemia, the doctor is going to say, no, you send him to the cath lab. So the cardiologist didn't so much rely on these studies, and they continued taking the patients to the cath lab for PCI. There was a huge observational study from Hachamovich and his group, and we looked at this for many, many years, and clearly, if the patient had less than 10% ischemic myocardium, there wasn't much difference in what they did. But if the patient had more than 10%, they did much better with revascularization than with medical treatment. And we based a lot of our knowledge on this. To evaluate, this was an observational study, and the patients were evaluated from 91 to 97. So they decided to do the ischemia trial. What they wanted was to evaluate in patients with ischemic heart disease, with stable angina, and moderate to severe myocardial ischemia. What is better, to send them for PCI plus optimal medical therapy, or to do optimal medical therapy? So basically, they took these patients with chronic coronary disease. Patients with GFR less than 30 were excluded. They did another trial with this. It was over 5,000 patients, half of them conservative, half of them invasive. And they followed them up for median of 3.3 years. They checked for cardiovascular death, MI, cardiac arrest, unstable angina, and heart failure. Half went to one group, half went to the other group. What do we mean by optimal medical therapy? They have to check on blood pressure, low density lipoprotein, HbA1c, and smoking cessation. These are the inclusion criteria. They checked with nuclear, with echo, with a cardiac magnetic resonance, and eventually, years later, they included exercise treadmill because the recruitment was so slow. Patients with left main stenosis were out, advanced chronic kidney disease out, recent MI out, patients with ejection fraction less than 35 out, unacceptable angina at baseline no, heart failure 3 or 4 no, and if last year they had PCI or CABG, they were out. You see also the Kaplan-Meier curves. and they concluded that over a median of 3.2 years of follow-up, if they initiate with invasive strategy, they did not finger is faster than the mouth. If they initiate with invasive strategy, they did not reduce the rate of primary or key secondary composite outcomes. Patients in the invasive strategy had more procedural infarctions and fewer non-procedural infarctions. So at the beginning, the ones in the PCI had more infarction, but long run, better. But why is that change? Why suddenly that change? Of course, at the end of the century, last century, we treated actually with nitrates, beta blockers, and aspirins. In this new century, we had statins, we had inhibitors of the renin-angiotensin, and the thienopyridines like clopidogrel, Plavix. So it has changed. On the other side, what happens with viability? We remember from many studies that if patients had quite an area of viability, they did better with cabbage. So they decided to do the STITCH trial. The main study, the aim was to evaluate the role of cardiac surgery in patients with coronary artery disease and left ventricular systolic dysfunction. The hypothesis was that cabbage plus good medical treatment, that would reduce mortality as compared to medical treatment alone. So they took 1,200 patients, half went for medical treatment, half went for medical therapy plus cabbage. Here you have the design. To make a long story short, they went for medical treatment or for cabbage, with or without the reconstruction of the ventricle. You see, for death for any cause, there is a mild difference when they follow them up to 5 years. Here you are, death of any cause. There is a bit less in the cabbage group. They concluded that there was no significant difference between medical therapy alone and medical therapy plus cabbage for death of any cause. But the patients with cabbage, as compared to the one with medical treatment, had lower rates of death, cardiovascular causes, and hospitalization for cardiovascular causes. But here we are, there was one arm of the STITCH that the patient had evaluation for viability. And in this group, they concluded that no significant reduction in all-cause mortality in patients undergoing viability studies. And very important, the viability testing, again, the viability testing did not identify those with survival benefit from cabbage as opposed to optimal medical therapy. So this is the arm that was checking myocardial viability. They saw that the survival without viability was less than the survival with viability. They concluded in this arm of the study that the presence of viable myocardium was associated with a greater likelihood of survival in patients with coronary disease and LV dysfunction. But this relationship was not significant after adjustment for other variables. Other variables means left ventricular ejection fraction and left ventricular volumes. And very important, they got to the conclusion that viability did not identify the patients with a differential survival benefit from CABG. The Stitch was a good study, had some strength. It was better than other studies. They had oversight committees that made sure that the therapies were optimal, very good surgeons. But the Stitch trial had some problems, and the problems were most of the patients, more than 60% had angina, more than 60% had class 1 or class 2 heart failure. It was difficult recruitment. Patients with significant left main were excluded. Also, patients with optimal medical therapy, 17% ended up having CABG. With optimal medical therapy, 6% had PCI. We said that the inclusion should be patients with ejection fraction less than 35. To make it, they ended up more than 18% having ejection fraction more than 35. It wasn't, the viability study wasn't randomized. The patients were at the beginning randomized, but they didn't randomize who is going to have a viable or a viability study. So at the end, only 114 patients from the 601 ended up having non-viable myocardium. It's too little. They only used SPECT and dobutamine echo. They didn't use CMR, they didn't use PET. Ischemia was not tested. Eventually, they checked if there was a difference at 10 years for the same patients. To make a long story short, there was no big difference at 10 years. So let me just, I won't go through the Revive trial. To make a long story short, they said if CABG could get some benefit, perhaps if we do the same thing, compare optimal medical therapy to PCI, we can also get a benefit. Long story short, 700 patients. The conclusion was that among patients with severe left ventricular dysfunction, with optimal medical therapy, revascularization with PCI did not result in lower death, hospitalization for any cause. So they concluded that the advantage, the little advantage that you got with CABG, they didn't get with PCI. And just to conclude, I know I am all the time. We talk about lifestyle interventions. We tell patients about lifestyle interventions. We tell them, you know, you have to eat well, you have to drink well, you have to exercise, you have to walk. Let's go to the facts. If walking and cycling is good for your health, the postman would be immortal. This is a whale swims the whole day, eats only fish, drinks water, and is still fat. A rabbit runs and hops and only lives 15 years. On the other side, the tortoise doesn't run and does nothing, yet lives for 450 years. So you take home your conclusion. Thank you very much.
Thank you, Professor Libhaber. I think that the end, you made it to the point that the people, they know what they select, who they want to be, which type of animal they want to be, it's up to them. Thank you again. There is a token of appreciation for you. But one message is that you told us that all these cardiologists, everything they do in intervention, most of the time is just to ask, why do they do it? Why do they go to the groin of the patient? It's because the groin is close to the pocket. I don't know. So we have just to watch and then see what will come in the future.